Hello, everyone. If you don't know me, my name is MJ. I'm a PGY3. For my social EM lecture today, I will be discussing the digital divide. Nice one, Rochelle. And I will explain what I mean by that throughout my lecture. And also, shocker, big surprise. That's what I'm doing. Okay, so first I will discuss telehealth. Then I will transition to why we use it, how it is implemented, and how the COVID-19 pandemic has affected its use, with specific focus on the ER. And lastly, who interacts with these systems and health disparities that can arise. So what is telehealth? Does anyone know? You want to throw out some words? Perfect, great. Anyone else? Apps. Great, all great. So the Center of Medicare and Medicaid Services, also known as CMS, defines telehealth as the exchange of medical information from one site to another via electronic communication. And emergency telehealth is remotely caring for acute illness, injury, exacerbations of chronic diseases, including initial evaluation, diagnosis, treatment, so on and so forth. Does anyone know what the difference is between telehealth and telemedicine? There is a difference. Okay, so we often use these words interchangeably, but telemedicine actually means specifically the direct provider to patient interaction using communication technologies, right? So it's more part of the patient-facing part of telehealth, and other parts include like MyChart or patient portals, like that kind of stuff, which you guys are a little bit more familiar with. Okay, so I pulled this from the 2016 ACEP emergency telehealth section, which lists some telehealth applications in different settings where it can be helpful. So these settings include, but are not limited to, pre-hospital, hospital-based ERs, freestanding ERs, correctional facilities or detention centers, and other locations like maritime, diving, cruise ships, and space medicine or disaster medicine. And by telehealth here, I mean, I'm referring to the direct provider to patient interactions via video conferencing, virtual visits, chat-based interactions, remote patient monitoring of like OBS units, like telemonitoring, or physician-to-physician consultation. And the list goes on, but this is what ACEP has. And here, specifically in New York State, we've developed a lot of pre-hospital EMS initiatives using mobile telehealth. The May 2022 newsletter from just last month, New York ACEP, highlights some of the mobile integrated EMS initiatives that we're using in community paramedicine. So specifically, medics are trained to provide patient-centered services like completing a full medical evaluation, contacting a telehealth provider for additional treatment options. And then one initiative we have here in New York is called the Emergency Triage, Treat, and Transport model, which is also known as ET3. I think they're cool, I guess, model. Also, that allows reimbursement by CMS for patients that are deemed stable for transport to an alternative destination rather than the ER. After consultation with a telehealth specialist. So that includes like primary care clinics, urgent care clinics, or community mental health centers. And the goal is to avoid unnecessary ED visits, hospitalizations, and readmissions for high-risk patients. So, which brings me to why we even use these methods at all. So why do we use telehealth? Yay! It's like you read my presentation. So the answer is the promise of convenience. So just think about it yourselves, right? How many times have you left a shift, had an appointment, whether it be a routine checkup or like a therapy appointment, and have been so grateful that you can go home, have a televisit instead of getting on the train, paying $275, maybe transferring, sitting in a waiting room for 20 minutes for like a 15-minute visit, right? The appeal is very obvious, particularly for those with busy lifestyles, us, or who are otherwise healthy or have very specific targeted healthcare needs. So telemedicine can help alleviate some barriers to accessing healthcare, including transportation costs, lost wages due to travel, arranging childcare. So all of these may seem small for us, but when you put them all together, they have the ability to have a very large impact, particularly for members of different communities. And so, for example, just one example, the US Transgender Survey is the largest survey looking at the transgender community in the United States, with over 27,000 participants. And respondents, they found that participants were 3 times more likely to have to travel more than 50 miles for transition-related care compared to their routine care. And like, can you imagine how large of a burden that is? Like, especially if you have to go multiple times a month, the cost, the time, it's insane, right? And furthermore, according to the National Association of Insurance Commissioners, approximately 18% of Black households do not have access to a vehicle. That is almost 1 in 5. Right? Those percentages are even lower for other communities of color. So 11% for non-white Latinos, 13% for Native Americans, 11% for Asian American Pacific Islanders lack access to vehicles, right? And by comparison, just over 6% of white non-Latino households lack access to a vehicle. So lack of access to a vehicle is especially problematic in rural areas because of the lack of alternative transit options. So telehealth has been a tool used in rural communities to overcome some of these obstacles for a while. So since 2003, the University of Mississippi Medical Center has operated a pretty good and robust telehealth emergency department network. They cleverly called it telehealth. Which increased access to emergency medicine trained physicians at participating rural hospitals. And they conducted a study looking at data collected between 2010 and 2017. And they actually found that tele-emergency was associated with an estimated 31% lower total annual ED costs compared to similar matched rural hospitals that did not provide this service. So prior to COVID-19, telehealth was pretty underutilized. NYU has a virtual urgent care that we all know system that has been running since 2018. And pre-pandemic, on a typical day, they had less than 100 visits across 5 states. So across New York, New Jersey, Pennsylvania, Connecticut, and Florida. And they managed a pool of about 40 ER providers who took visits either at home or on site. And the primary objective being to help specialists kind of avoid travel to the ED and cost saving from unnecessary ED visits. So, but clearly COVID changed everything, which I'm sure everyone in this room is aware and probably tired of hearing by now. But at the beginning of the COVID pandemic, the obvious added benefit was that patients were able to obtain care without risking infection or transmission of COVID. And our focus has shifted to using telecommunications primarily to reduce virus exposure, decrease visit volume, and conserve PPE. And so there was a rapid creation and expansion of ED telehealth programs during the pandemic, and we're no exception here at Kings County. There has been an explosion of IT innovations in our own department and across the hospital. And you might recognize Dr. Salway and Dr. Way on that paper that discusses the way we bridged information systems citywide to improve access to crucial information. And some of our faculty have also been involved in conducting virtual urgent care visits. But just like most things in medicine, access is not equal and utilization is not uniform. So as you make progress, it always seems to highlight new obstacles and new inequity. So as you go up, you are actually coming down. So that's why that. So which brings me to the main point of my lecture, the digital divide. So the use of technologies has the potential to exacerbate disparities via the digital divide. The disparate access to and utilization of technology and internet among communities and populations of diverse race, ethnicity, socioeconomic demographics due to language, social, financial, and other barriers. So like any intervention, we want to ensure reach, adoption, and long-term sustainability. So when I say reach, I mean that we are accessing the patient populations with the most need and providing them with the proper tools and platforms necessary to interact with the system. And we want to make sure that they have the proper training and understanding on how to adopt and adapt to telemedicine, with the ultimate goal being long-term sustainability, because telemedicine initiatives are going to continue to expand. Right. And the hybrid in-person visits with televisits are here to stay and only going to become more widespread as we create more infrastructure that's necessary to support it. So we must look at the different levels where obstacles are created in order to know how to intervene and to prevent disparities amongst patients. So let's look first at the patient level. So 1 in 4 Medicare beneficiaries experienced a televisit during the pandemic, which is obviously higher than pre-pandemic. In 2021, more than 36% of seniors had no broadband internet at home, like none. And the gap in rural areas was even larger, which is especially substantial when considering they may have less access to care to begin with. And compared to any other age group, patients 65 and older had significantly higher odds of using the ED or office visits versus telehealth. And one study published in the Journal of Informatics and Health and Medicine, looking at characteristics of telehealth users here in New York City, found that Black and Latino patients over 65 had the lowest predicted probability of using telehealth compared to all other patient demographics. And it was about 11%. And this may be due partially to like limited digital literacy in this age group. Okay, and so I'm not going to go into this too much, but this is from the NYP Direct to Consumer Telemedicine Program that is a virtual urgent care platform for EM and PEM providers. And in this geotagged study, they compared COVID positivity rates and telemedicine use all over New York City. In the paper, they focused on comparing Yorkville, which is in the Upper East Side, for those of you who don't know, with Corona, Queens. Which has a much higher density of non-white Latino patients. And they chose these 2 locations because they were equidistant to the NYP main site. And as you can kind of grossly see illustrated here, the locations with the highest COVID cases by zip code in purple also had the lower number of virtual urgent care visits. That's all that was supposed to illustrate. Okay, and in the previous study that I mentioned, examining the characteristics in New York City, African Americans had 4 times the adjusted odds of using the ER compared to telehealth visits. And likewise, for non-white Latinos, ORs, the odds ratios were about 2.5. But why does this matter? Why does it matter? As long as they're seeking care, right? What's the difference? No, wrong. They may delay care or not seek it at all for the reasons that I previously discussed, leading to worse health outcomes, especially since they were disproportionately affected by COVID. Okay, and then some other facts. Among all telemedicine users, the same study also concluded that patients who had less education, which is also not surprising, were unemployed, were retired, or had a disability, were more likely to complete a telephone visit compared with a video visit, which also has implications. So just like remember that, that I will discuss later. And then lastly, language barriers. Always obstacles, but can dissuade users from setting up patient portals, accounts, troubleshooting issues, or even logging in at all. And all you have to do is think about our patient population here. How many times have any of you tried to explain my chart to your patients? Literally anyone over the age of 60, anyone who doesn't speak English, any of those, like how much more difficult is it to try to get them to sign up for my chart? You don't even bother sometimes, right? So some, if not many of the characteristics I mentioned apply to a large contingency of the patients that we see on a daily basis. So the second tier that we're going to discuss is the healthcare system itself. So even if you manage to overcome all the barriers to get your patients logged in and ready for your patient encounter, one study actually suggested that lower levels of digital literacy independently can lead to patients being less engaged and having fewer psychological benefits from telehealth interactions, even when they do participate. So inadequate digital literacy is also not just a barrier for our patients, but also for our health professionals. Right? So I looked at one systematic review looking at various different studies on telemed in the ED. And 3 of the 18 studies cited technical issues and difficulties and increased anxiety in the hub physician as obstacles for providers. And the US Department of Health and Human Services provides resources on their website for providers who are not yet comfortable with using telehealth, but it's still like very limited, and different platforms have different specific instructions. So if you're like going to different hospitals or you work at different sites, that could be something that's important to you. All right, so next let's examine the infrastructure itself. So I touched on this a little bit earlier, but limitations in broadband access is one of the main barriers to increasing access to care for underserved Americans through telehealth. It's a little bit old, but as of September 2020, it was estimated that 19 million Americans lack any access to broadband internet. 79% of white individuals are home broadband users compared to 66% of Black and 61% of Latino individuals. And alarmingly, 25% of Latinos and 23% of Black individuals are reliant on smartphones for internet access compared to only 12% of white individuals. And this was the 2018 report by the New York City Mayor's Office. Found that more than half, so approximately 56% of New York's lowest income households lack a home broadband subscription here. Thankfully, they've been able to expand this a little bit since the pandemic due to partnerships with private internet providers because of things like required Zoom school for like children, but I was unable to find like the latest stats on that. And then also in households where individuals share rooms, there's overcrowding or multi-generations. There may not be spaces at home for them to have private patient encounters. They might seek other avenues, including the local library, to allow for sensitive conversations, but even that isn't guaranteed. And computers and internet access at libraries are particularly used by African Americans, Latinos, and those in lower income households with a gross income of less than 30,000. So according to the Pew Research Center, now in 2022, like who goes to the library anymore, right? But like now in 2022, 30 to 40% of Black, Latino, and lower income, so less than 30,000 a year, library users are using the library primarily for the computers, the internet, or the Wi-Fi. So this is a copy of the guidelines for my own televisit confirmation. And so I'll let you kind of read that for a second. I just screenshotted it. So as you can see, there's a no-show fee if you have any issues whatsoever. So whether it be that you can't connect to the audio and video at the same time, or if you're not joining from a private space, they're going to charge you a no-show fee, which is crazy. And also I wanted to mention that another consideration is that these televisits might require upfront payment, whether through the use of a debit or credit card, which may also be a hindrance for the undocumented or the cash carrying low income patients. Okay, so let's say now that after overcoming all of these obstacles, you are finally able to connect with your patient. Now you have to worry about technical issues, right? One study I looked at interviewed 15 different ED providers across 10 different states at 10 different institutions, and they had very similar things to say about participating in virtual urgent care visits at their site. So participants mentioned equipment failure, equipment shortages, connection issues, limited cell service in rural areas, device incompatibility with their available software, lack of EMR integration, limited functionality, as all factors that undermine their telehealth programs. But however, after technical issues, the second most cited complaint was the gray area of legislative, ethical, and policy issues that surrounds telehealth implementation. So that brings us to our last level, policy. Pre-pandemic, the reimbursement model favored in-person encounters. That's just what it was. That was the system before. And there was also lower reimbursement for audio only versus video visits. So remember what I was saying about patients with disabilities and stuff, they were more likely to do audio only visits. And there was a lower reimbursement model for that. But in March of 2021, the Centers for Medicare and Medicaid Services announced significantly expanding telemedicine coverage for Medicare beneficiaries, and all states have expanded their telehealth access for Medicaid as well, and private insurers are not that far behind. So some of these waivers, though, are really temporary, and it's unclear if the reimbursement models are going to continue as we move into the post-COVID surge era. So it's still kind of unclear. So just to review and explore some solutions to the obstacles that I described, because it's not all bad, right? So for patients, designing and offering training programs, whether it be through telephone, mail, community centers, churches, whatever, can help bridge kind of the internet knowledge and skills gap, especially among older adults. Oops, sorry. Yeah, and this can also be done at point of care. So use your case management colleagues or your care coordinators if you can, if they're available. Second, continued institutional commitment to equity in telemedicine, including training our staff to become more familiar, is important. The FCC actually announced $200 million in funding. That's kind of like dog-eared or ear tagged, I forget what it's called, in the CARES Act. So that is dedicated specifically to telehealth services for its COVID-19 telehealth program. Adapting televisit technologies to launch on different types of smartphones across different web browsers. Like sometimes you can open it in Safari, but you can't open it in Google Chrome. And if you don't have one or the other, you're up the creek, right? So, or creating web portals catering to those with hearing and vision impairment, and also ensuring multi-language availability for non-English speakers are all very important. Then lastly, at the congressional level, broadening the reimbursement model that I talked about, and also considering reimbursement for education initiatives, because those are very labor intensive, right? And in June of 2020, Congress introduced the Accessible, Affordable Internet for All Act, proposing $100 billion for broadband expansion, with 20% allocated towards digital equity programs. And broadband service for low-income consumers. But this act still has not passed in the House. So that was a lot of information, and I probably talked a little fast, but here are my main take-homes. So remember, your older Black and Latino patients or patients that don't speak English have a much lower odds of completing a telemedicine visit and are more likely to end up in your ER despite having a higher disease burden. Second, lack of digital literacy or broadband access for vulnerable populations also stands in the way for universal access to care through telehealth. And then last, Medicare and Medicaid telehealth reimbursement expansion is likely temporary, but continued policy and institutional investment is key to kind of alleviating some of these inequities. So thank you. Questions, and those are my references.